My name is Daniel Galvao. I'm a professor of exercise science and the director of the Exercise Medicine Research Institute at Edith Cowan University in Perth. And I want to thank the Prostate Cancer Foundation for the opportunity to share and present some of our research studies undertaken here in Australia, and some of these studies also undertaken internationally. So the title of the talk is Exercise Medicine Across the Disease Trajectory, the prostate cancer trajectory from early stages disease all the way to patients with more advanced disease, and how exercise can actually help patients throughout that journey. As with many other cancers, patients, they do experience toxicities and side effects from a number of types of different therapies, including chemotherapy, radiation, surgery, specifically for prostate cancer, ADT or androgen deprivation therapy. Others know that particular type of therapy as hormone therapy, and also other types of systemic therapies for prostate cancer. So patients, they do well. The treatments are effective in a number of ways, but patients do experience side effects. These are short-term and long-term side effects. We did propose a model. This is now going back nearly 13 years ago, suggesting that ADT specifically, this the hormone type of therapy, which is extensively used in the management of prostate cancer, also accelerates aging. Patients often, they lose their muscle, they have a loss of bone mass, they have issues with metabolic complications with ADT, they get abdominal obesity, fat accumulation, and as a result, there's also a reduction in physical function or a decline in physical function. So we proposed, this is a number of years ago, that exercise, specifically a mode of exercise, which is resistance training, which I believe Professor Newton has already explained and defined in his presentation, which is a type of a modality that you're sort of working against a resistance, aiming to build muscle or leading to muscle hypertrophy, can actually offset a lot of the toxicities associated with ADT in men with prostate cancer. And just as a parallel, this is in the field of breast cancer. Others have also proposed that, for example, women with breast cancer, they have also issues with cardiovascular disease before therapy. And this multiple hit hypothesis has been proposed a number of years ago, that an increased risk of cardiovascular disease is exacerbated again due to systemic type of therapies for breast cancer, and then leading to cardiovascular disease and cardiovascular risk. So it's sort of showing two different interesting ideas, that cancer therapy leads to toxicities, and these can be musculoskeletal toxicities and side effects, and also cardiovascular complications and metabolic complications. And if you think about exercise it is somehow a new research area and a new clinical area. First study was really only done in the 1980s, which is not a long time ago. Exercise, the first study was done in breast cancer. This is the history of exercise oncology. And at the time, clearly clinicians would advise patients to rest. Exercise was absolutely contraindicated for cancer patients. And hopefully by the end of this talk, you will understand how important exercise is these days. And it's actually part of medicine. It's an adjunct medicine to normal pharmaceutical interventions and treatments for cancer. But at the time, the concept was so new. This is in the 80s. And then in the 90s, there was only about 7 published studies, none in prostate cancer. So this area emerged in prostate cancer just really more recently, in about 10, 15 years ago. We had a comprehensive review. This is done from our team, a review that was published in 2005. Now, this is about 15 years ago, when we look at all these studies that were done in the area of exercise in cancer. And again, majority of the work done in breast cancer, almost basically no work done in prostate cancer by them. The preliminary data that was that we took from this literature was that exercise could potentially improve some of the psychological outcomes for patients, and also physiological outcomes. Patients would feel better and potentially would reduce some of the adverse effects from therapy. This is primarily in breast cancer. So from there, we thought there's this huge gap in the literature, and we started to do a lot of work and research in this space. of exercise for patients specifically with prostate cancer. And I'm going to talk about some of these studies that was actually done here in Australia that has been really a lot of the findings from these studies have been adopted globally in many countries. Important, and you're familiar with some of these statistics, a lot of the patients with prostate cancer, they have localized disease because of PSA, so the disease can be really picked up earlier in a lot of cases compared to other cancers that don't have a blood test, for example. And as a result, a lot of the patients at diagnosis, they have localized disease. And the window for survival, it's exceptionally high for prostate cancer. The large majority of patients, that 5-year window, it's 100% survival here in Australia. Clearly, if the disease is advanced, that survival window, it's lower. But what that means from an exercise perspective or lifestyle perspective, that men are living longer, but they're not necessarily living well with prostate cancer. And again, that's how exercise can actually help reduce a number of the toxicities and issues that patients will experience. There's a number of therapies, and this is important because when we're referring to exercise, I think the prescription of exercise might change depending on the stage of the disease and depending on the treatment that the patients are actually experiencing. Of course, there's active surveillance, which is a non-treatment approach that patients are monitored over time. The surgical approach with prostatectomy, radiation therapy that is used in different stages of prostate cancer, androgen deprivation therapy. We'll talk a lot about androgen deprivation therapy or ADT or hormone therapy. The reason is ADT leads to a number of issues and toxicities that they're not pleasant, and exercise can help a lot in that setting. And of course, patients that have more advanced disease, there are also systemic therapies and new anti-androgen drugs that are being extensively used now and helping patients substantially. So when we think about exercise, again, when we're talking about the disease trajectory, exercise has a role in prevention, but that's not the focus of the talk today. In fact, exercise is well established to prevent 7 cancers, not prostate cancer, though the data it's mixed for prostate from a prevention perspective. So we're gonna be talking a lot about exercise helping preparing patients for therapy. Exercise helping patients coping with the therapy and potentially even increasing the efficacy of the therapy or the tolerance, which is an important area of research, and we're gaining a lot of new knowledge in that space now. For those that have completed their treatment, the role of exercise in rehabilitating patients, again, from toxicities of ADT or radiation, for instance, and how exercise can actually help preventing other diseases. These are patients that have completed that therapy and during the survivorship stage. And patients with advanced disease, how can exercise can be implemented? Again, just more recently, exercise was hard to be prescribed for these group of patients. Our group developed a model, an interesting model that we'll discuss a little bit later, that even with patients with bone metastasis, for example, a prescription of exercise can be done safely. And the potential influence of exercise on survival. So from a prehabilitation perspective, now this is an interesting area that's getting a lot of traction nationally and internationally. And the concept is, patients will have their physical function if they are exercising before a major surgical event, including radical prostatectomy, for instance, they have a greater physical or functional reserve capacity. And as they have their surgical procedure, bed rest, and they tend to waste muscle, they tend to lose their function, especially for more complicated surgical procedures. And if the patient has a greater window, greater reserve, they tend to do better at the long term when there's a post-rehabilitation period. So we thought about doing this work in prostate cancer. This work was published a couple of years ago by Dr. Fevil Singh, that we had patients exercising just before radical prostatectomy. And then we had patients not exercising right after surgery. And then we had measurements done a couple of weeks after surgery. And this is the interesting finding and kind of expected, patients, this is at baseline before they exercise. And so right before surgery, they improve. This is one example, muscle strength. They improve their muscle strength. They also improve their function. There are a number of measures of physical function. And at post-surgery, you would expect these patients to decline quite substantially. And they are, in a way, preserving almost their muscle strength over time. So suggesting that exercise prior surgery might lead to some beneficial effects in improving their physical reserve capacity. This work wasn't translated in hospital stay, length of hospital stay, but there's some current studies and work actually looking at more clinical outcomes to complement these early findings that exercise as a pre-habilitation might help patients over a long term following surgery. There's some also indications that that might also potentially improve issues around incontinence as well. Another interesting study that our group is actually conducting, there's a study that was recently completed in Canada. They're about to publish their work with some interesting findings is in the space of active surveillance. So these are patients with very early disease. They not necessarily need surgery at that stage or radiation therapy. So they've been monitored. So this is an interesting work funded by the National Health and Medical Research Council. It's a study trial that we're running in Western Australia and also in Melbourne, and the study is open for enrollment. They were randomizing patients for exercise during active surveillance or no exercise. And the idea here, the hypothesis behind the biological potential mechanisms that exercise might actually help delaying disease progression or PSA progression. It might improve a number of aspects of psychological distress and quality of life and body composition. So we're looking at as a primary endpoint here is time to surgery or time to radical therapy. So there is important pilot data suggesting that patients that are more active during active surveillance, they're less likely to have the disease progressing. This is a large study that's currently underway examining this exact question. So we don't have the data as yet, but it's a very important space as we have more patients going into active surveillance. So we're looking at the aspect of disease trajectory for patients that are on therapy, and this will happen a lot in relation to ADT and radiation therapy. A number of important studies. Interesting, this was a study from our group that we aim to track. This is the first national study, Australian study, looking at changes in body composition over time for patients that were starting androgen deprivation therapy. And we look at these patients over 36 weeks, the initial 36 weeks. And as you can see, PSA drops substantially when you're starting ADT, nearly 100% reduction in PSA. Testosterone substantially reducing, which is a good thing to control the cancer, but the lack of testosterone also has negative implications to a number of body composition components. Here we're looking at lean mass or muscle, appendicular skeletal muscle, so mainly the upper limbs and lower limbs going down, which is problematic. Patients are losing about 1.5 kilos of muscle, lean mass over this short period of time. And if you think about the first slide, when we thought about the aging process, a lot of these patients, they are over 60, 65, 70 plus. There's an acceleration of this loss of muscle, which we call sarcopenia, which can be problematic and impact daily activities. In addition to the loss of muscle, there is also a substantial gain in fat mass and also trunk fat, which is problematic because it might increase the risk of cardiovascular disease. So as we see over time, even when patients, they stop their therapy here at 9 months or 36 weeks, so there's this increasing fat mass, there's this reduction in lean mass. This is very, very clear. And this study has been replicated by a number of groups internationally. So it's really well established, these changes occurring in body composition in men with prostate cancer undergoing ADT. Interesting, when they stop therapy, the change not necessarily, see the gaining fat mass, they don't necessarily come back to baseline. Same for muscle. So exercise has a very important role here in facilitating, in rehabilitating these patients here in this space of changes in musculoskeletal health for men undergoing androgen deprivation therapy. And we're going to talk about some of these studies. But not just the changes in body composition, muscle, and fat. We also shown previously, and again, this was also confirmed by a number of groups internationally, that these patients on ADT or AST, androgen suppression therapy, they become slower, their function is impaired by the loss of muscle, not surprisingly. So they tend to become weaker. They have lower physical function abilities. And again, this is problematic because this might affect their daily activities. They get tired much quicker and so on. So those are the changes in muscle strength and physical function. And interesting, and in the long term, and we spoke about muscle, fat, physical function, there's also issues around bone mass, well established. And when testosterone is withdrawn, again, positive for the prostate cancer itself, but patients, they lose bone mass, which testosterone is important for bone mass. This is just one example of a study looking at patients over time, over a decade. Patients, they tend to lose bone quite substantially over 10 years. A large proportion of patients on ADT will develop osteoporosis, which is the loss of bone mass, which can be a problem because it can lead to potential fractures in the future. So again, exercise might help patients here in preserving bone. We'll talk about one or two studies in this space, and also improving balance and function. So patients are less likely to fall in the first instance, and potentially and protecting themselves by having more physical abilities. So this is an interesting study done by our group. This is nearly 15 years ago. This was really the first study done nationally and internationally looking at the potential role of resistance training. Again, I think I said before, Rob Newton had a definition of what's resistance training, what's aerobic training. I won't be repeating all that. Just in briefly, resistance training, working against resistance, trying to build muscle. There's different ways to prescribe resistance training, and aerobic training is a way of improving cardiovascular function, more metabolic function, as opposed to resistance training. So there's those two main exercise modalities. So what we saw in this study, we had patients, this is an early pilot study with 10 patients on ADT without testosterone. And at the time, we really didn't know if patients would actually respond to a program, because again, testosterone is also important to improve muscle mass and muscle strength, in addition to resistance training. These patients, they were able to improve muscle strength. We're giving some examples here over time at 10 and 20 weeks. And the changes in muscle strength was also translated in changes in physical function. So they also improved physical function. That's almost an important clinical measurement. So improving strength, yes, and you're translating this into function. So your activities of daily living are easier to be undertaken. So an important early study showing some indications that resistance training specifically can offset some of these toxicities from ADT. So we expanded this work subsequently when we combined the prescription that we've tested in this second study was when we had resistance training in combination with aerobic training. So it was a combination of the two exercise modalities, resistance and aerobic training, moderate to high intensity, not too long. I mean, about 15, 20 minutes aerobic training twice a week, and resistance training 2 to 4 sets, 6 to 12 repetitions. RAM refers to repetition maximum. So the maximum weight you can lift between 6 and 12. So we compare this intervention to usual care. These were patients on ADT, all the patients, and some of these patients were also receiving radiation therapy. Again, these are patients with local disease, not with advanced or metastatic prostate cancer. And this is defined, it's a complex slide, but the summary here is that this is the difference between groups at 12 weeks. And we're looking at muscle, okay, lean mass by DEXA, which is the best sort of possible technique to assess lean fat mass. And we're seeing the difference in favoring the exercise group. So the exercise group, this is in kilos, and pretty nearly 1 kilo. That's the difference between exercise and controls. I mean, they both on ADT, one group is receiving the intervention, the other group is not. At 12 weeks, the exercise group is preserving, improving. The difference between groups is about nearly 1 kilo. It's about 800 grams for whole body and also appendicular skeletal muscle. Importantly, from a patient perspective, these patients are also feeling better. Their general health is improving. Their vitality, which is the opposite of fatigue, is also improving. So they're also improving their self-reported health. This is measured to questionnaires. In the case here, it's the SF-36, a well-known questionnaire for quality of life. So the summary here of these studies, that exercise, okay, we look at the previous studies, improves function, improves muscle strength. Here we've shown that exercise can preserve and even improve muscle mass in these patients. Quite important because the acceleration in the loss of muscle mass is quite quickly with ADT. And also patients are feeling better, which is a very important outcome. And I'm going to talk about a third study. This was a large NHMRC study, National Health and Medical Research Council funded. This was a 3-arm study. It was funded potentially a decade ago. Study was completed a couple of years ago, and there's a lot of publications coming out of this work, some very unique studies. This is the largest ever exercise intervention study done internationally at an international level in men with prostate cancer. So here we had 163 patients nationally in Queensland and also in Western Australia. Majority of patients were from Western Australia. They were all on androgen deprivation therapy, hormone therapy, and a large proportion of these patients were also receiving radiation therapy. So mainly patients with localized or local advance, not with metastatic disease, bone metastatic disease, or distance metastasis. Some had nodal metastasis. So these patients were randomized in 3 groups, and here we're looking at the potential role of exercising helping their bone mass or bone health. This was an osteogenic, as we call, exercise group, aiming to preserve bone. So in addition to resistance training, aerobic training, patients also did impact loading training. I think Rob presented some of these videos previously. So impact loading, which is the best exercise modality to preserve bone, and this is well known in the literature in other groups, other patient groups, although this is being tested for the first time in men on ADT. We also had a more traditional exercise program, which was the resistance training and aerobic training only, no impact loading. Again, moderate to high intensity training. And we also had a delay group, a usual care. They didn't exercise for 6 months, and then they had some exercise from 6 to 12 months. So it's a year-long study, quite long study from an exercise supervised exercise training program perspective. And what we see, I think this data was presented by Rob, is that with ADT, we saw that patients, they lose bone quite substantially over time. A lot of these patients would even develop osteoporosis in the long term. So what we see that the delayed and aerobic exercise, they're losing bone over time. This is the 6 months and 12-month data. Interesting, the group that did aerobic and resistance training without the impact, they also lost bone quite substantially. This is lumbar spine, BMD, over time. And then the group that did the more osteogenic targeted exercise group, that did resistance training and plus impact loading, which is the best modality for bone preservation, were able to preserve. So the message here is that not all exercises will lead to the same benefits. So exercise modality or specificity, it's important when the outcomes of interest are being used. So, and when we talk about other outcomes, things like fatigue, exercise, any exercise modality might be beneficial. But here for bone, specificity is very important. And there's another example here on specificity for VO2, which is cardiovascular function, cardiorespiratory function. Exercise group do better. They do better when including an aerobic component of exercise compared to no exercise. So when cardiovascular training is undertaken, these patients are likely to improve their cardiovascular function, which makes sense. But there is this specificity aspect of exercise. And again, we briefly spoke about fatigue, but that's not the case though for fatigue. Any exercise across all the 3 groups, they all benefit. All patients improve fatigue and all patients improve their vitality. And what's even more interesting is that the patients that had higher fatigue had a greater response. The patients that had lower vitality had a greater response. And again, just coming back to some of the previous slides, depending on the outcome of interest, of priority, the exercise prescription will be changing, will alter. If fatigue is an issue, really any activity is okay and will lead to benefits. But if it's muscle waste or muscle loss, a resistance training program is important. And if it's bone loss, some type of impact loading activity, it's also important. And then we move into that survivorship perspective of disease trajectory. And we're going to talk about one large study that we undertook for patients that had completed that therapy. This was part of the RAIDER study in combination with our colleagues from University of Newcastle a couple of years ago. This study was done in patients that had completed the radiation and also the androgen deprivation therapy treatment plan. So they're no longer on therapy. They were slightly an older group of patients, some of them at their 80s and even older. So we had 100 patients randomized to exercise or usual care. The usual care was a printed material, educational material about physical activity without a prescription per se. And the exercise group, they had 6 months of intervention of supervised exercise. And then from month 7 to month 12, they received a prescription, but it was a home-based program. It's interesting, I mean, all this telehealth era that we're going through now with COVID-19, this study has important applications to home programs, because half of that study was actually done at home with supervision being done without face-to-face supervision. So these patients, they were, again, more than 5 years post-diagnosis, local disease, no metastatic disease, and the study was undertaken in about 14 exercise clinics throughout Australia and New Zealand. So these are the findings. And again, the first 6 months, patients were highly supervised by an exercise physiologist. And then the following 6 months, they had a home exercise program. So we look at it here, time. So if they reduce their time for physical function, it's an improvement in the outcome. 400-meter walk, it's indirect measurements of walking endurance, as well as chair rise to stand. It's more a muscle, indirect measurement function for muscle power, ability to go up and down quickly from the chair. You see the exercise group, they're reducing their time, they're getting better, and they are able to preserve that when they're exercising at home. It's interesting, from 6 to 12 months. We call the physical activity group, the educational material that didn't have a prescription, they didn't change much over time. And again, chair rise to standing, the functional tests, patients, they get quicker, they improve, and there's some sort of maintenance, and very little change for the other group. From muscle strength perspective, again, if you're going up, it's better because you're increasing muscle strength. And 2 examples here for upper body and also for a lower body exercise. Patients do better, supervised, they improve, and then they preserve, they improve, and then sort of preserved. And again, just to remember, these are patients that have completed ADT and radiation, and this is an older group of patients. So yeah, patients can adapt quite well in a supervised exercise program post-treatment, and they can preserve a lot of these benefits over time. So these are the changes taking place from 0 to 6 and 6 to 12 months. And I think an important aspect, again, self-reported outcomes, and this is the quality of life being measured, physical function, self-reported physical function. This is the exercise group doing more or better in addition to the usual care. So better for physical function at 6 months and 12 months. Interesting, the social functioning aspect of some of these subscales, the patients do better at 6 months, but then when they go home, that social interaction disappears. So that loses out from 6 to 12 months, which is an interesting piece of data. Patients, they do enjoy being together, most of the patients in exercise sessions. Some changes as well for role emotion and also mental health composite score for 6 months, but not 12 months. So interesting data there from a self-reported aspect from these patients. So in summary, from that group of patients that had completed that therapy, they're not on active therapy, they still respond, they do better, they improve their physical function, their muscle strength, and a lot of the self-reported outcomes is also improved over time. And including older patients, these are older patients with prostate cancer. Now, we're briefly going to talk about patients with advanced disease, and not a long time ago, but these patients would normally be excluded from exercise studies. This was the first study done internationally at looking at patients with advanced metastatic disease, in particular bone disease, bone metastasis. So we had about 57 patients there, and these patients, they had extensive disease, metastatic disease in their bones. 75% of these patients had pelvis metastasis, 40% femur, 67 lumbar spine, 44, and also upper body about 25%. Large majority on ADT, some on chemotherapy at the time. The study was done more than 5-6 years ago. A lot of these new drugs, abiraterone and enzalutamide, they were not even available at the time when this study was done and completed. and also radiation therapy for mostly for pain. So we've tested the potential role of exercise in the setting of patients with advanced metastatic disease. And the concept here was to use a modular exercise program we call the M3EP. And the idea with this program was to try not to target the areas that had bone metastasis or lesion. So if someone had a lower body metastasis on the proximal femur, they wouldn't do a specific lower body exercise, but they would be okay to do upper body activities. Same with weight-bearing activities. They wouldn't be doing heavy weight-bearing if they had metastasis in the lower body, but they would be okay to do some upper body activities. So the idea was to go, the concept was to go away from the actual lesion, even because a lot of these patients, they can deteriorate very quickly, and chemotherapy, again, can lead to fatigue and other issues. So we thought about trying to incorporate an exercise program that would be safe and tolerable by these patients. And these are some of the data from a safety perspective and compliance perspective. A lot of these patients were able to attend the sessions. We had really no exercise-related adverse events and skeletal fractures, which is a concern initially, a concern from clinicians about these patients' exercise. But important to have it in mind that this was a very conservative program, and it was supervised by an accredited exercise physiologist. The intensity of the program was acceptable, moderate to high intensity. The tolerance, they perceived the tolerance being very high in a scale from 0 to 7. Bone pain very low with the program. And again, bone pain assessed by specific questionnaires didn't change over time. So from a safety and feasibility perspective, these patients were able to exercise quite well, these men. And in addition, we also had some preliminary efficacy data suggesting that physical functioning also improved over time. This is a clinical meaningful change of 3 points in that scale from the SF-36. And also lower body muscle strength also improved in these in these patients, about 6 kilos, nearly 7 kilograms, which is an important finding for these men that have advanced disease and also have compromised physical function. So they felt that they improved their physical function, and they also objectively improved their muscle strength. So in summary, patients with advanced prostate cancer, there's programs that developed, the well-based, evidence-based programs that can be undertaken. It seems to be safe and efficacious to improve outcomes for these patients. And now about survival, the area of exercise is moving a lot. And again, this is a lot driven by a number of epidemiological studies suggesting that patients that are more active, they just don't do better from a quality of life perspective, from treatment toxicities reduction, but they might even survive longer. And this is data from a number of epidemiological studies. This is including breast, colorectal, and prostate cancers. More studies in prostate cancer. At the time, there was about 4. This work was published in 2016, this specific review, suggesting there's a risk reduction, about 37% risk reduction for patients that are more active compared to those that are less active. With breast and colorectal cancer, their survival is increased. So there are a number of large international studies examining, and this is specifically in prostate cancer, clinical trials, prospective studies, randomizing patients, and this is the GAP4 funded by Movember. If exercise can actually improve survival in men with advanced prostate cancer. This is based on this important epidemiological data. And in fact, exercise is being termed as a medicine in oncology. This is an important publication that took place last year. Our group had an opportunity to contribute to this work. We're actually, in fact, representing Australia in addition to 17 partner international organizations, including the American College of Sports Medicine, American Cancer Society, American Society of Clinical Oncology, putting together this important summary of the field across all cancers in relation to exercise. So we briefly spoke about prevention. It's less applicable to prostate cancer, but exercise might have a role in preventing many cancers, 7 cancers. We spoke about this epidemiological data for those with cancer, breast, colon, and prostate cancer. There's this association, clear, consistent association that exercise might improve survival for these patients. And again, phase 3 clinical trials are currently being undertaken to establish this cause and effect relationship. Very clear data. This is in prostate and in other cancers that exercise improves fatigue. We presented data here in prostate cancer. Psychological distress, and this is anxiety and depression. Again, there's accumulating data now in prostate cancer. Physical function, quality of life. So exercise helps with a number of these aspects. And this work's also indicating how, more research on how can we actually integrate now exercise medicine as part of a treatment plan for patients with cancer, including men with prostate cancer. And again, PCFA is doing a fantastic job with forums like this, so we can disseminate knowledge and hopefully get patients involved in exercise programs. And another interesting area is how exercise can influence tumor biology. I think Professor Newton spoke about some of these aspects, and I'm going to briefly touch some of these areas. So we spoke about exercise being important to improve quality of life, reduce toxicity. Exercise might improve the tolerance of the therapy, in particular for chemotherapy and and treatments that are very toxic. So by improving lean mass, improving physical function, improving immune function, and reducing side effects, patients might be able to better tolerate therapy. That's one potential mechanism. Another one from treatment efficacy, again, because of the survival benefits we're seeing in epidemiological studies, and they are to be confirmed in phase 3 clinical trials, there's biological mechanisms of how exercise might actually be leading to these benefits. Some are the intratumoral. They were looking at the actual tumor vascularization. This is being done in preclinical models, as in animal models. Exercise might improve the perfusion, blood flowing to these actual areas within the tumor, and might reduce the hypoxia, which is the lack of oxygen. Low oxygen is actually detrimental. It makes the cancer, the tumor, more aggressive. So exercise might facilitate the reduction of hypoxia and even bringing cells, immune cells, to the actual tumor. And even what's being suggested that it might even increase the sensitivity of these drugs like chemotherapy, make it more chemosensitivity due to exercise. So facilitate the infiltration of particular natural killer cells within the tumor. So there's a range of different mechanisms that are being studied now. That exercise, again, it might not just be seen as good to improve quality of life. Psychological distress and toxicities might have a role in improving tolerance and the efficacy of the treatment. And on this, I'd like to point out our team is actually doing some very unique work in this space of treatment efficacy, in particular for those patients with undergoing radiation therapy. As we spoke, as you can see here on your left, at rest, this is the tumor perspective. The vessels are narrow. At rest, there's low diffusion of oxygen. And with exercise, these vessels, they might enhance in size, they might increase perfusion, and they might facilitate the delivery of oxygen within the tumor. And this might facilitate, or even the efficacy, or might improve the efficacy of radiation therapy. And we're doing this exact study now as we speak, funded by Cancer Council WA, some early study that we're having patients doing their MRIs before and after exercise, and we're trying to understand the perfusion within the prostate cancer, if this is actually facilitating perfusion and potentially improving the efficacy of radiation therapy. And over time, we're also looking some blood biomarkers for oxygen level or hypoxia. So interesting piece of work suggesting that exercise might improve the efficacy of the treatment. So it's really using exercise as an adjunct therapy to traditional interventions that are important already. So some considerations, there's a lot of information there. There's emerging evidence of exercise on the pre-treatment stage. Clinical endpoints are still lacking, particularly in the area of active surveillance, where the studies are on the way. Patients that are about to have surgery, exercise seems to be beneficial to improve function and muscle strength over time, so they tend to do better after surgery. Evidence for exercise during treatment, there's extensive evidence now from a quality of life, psychological distress and function perspective, and also physiological perspective. Although we spoke about specificity, not all exercises will work for everything. So specificity of the exercise is important, targeting the right exercise. For some outcomes like fatigue, any exercise is beneficial. emerging evidence on the exercise prescription in patients with advanced disease. And again, the model we've presented and tested is being used nationally and internationally by many, many groups. This modular component of bone metastasis, it can work and you can exercise around and you can go away from the metastasis site, specifically the bone metastasis. Data on clinical disease outcome is still underway, and studies like GAP4 will be informing that. There's also consistent epidemiological data, which is really exciting, about prostate, breast, and colorectal cancer, making these associations between higher levels of activity and greater survival for those patients with cancer, which is very important. Data, and it's leading to this mechanistic type of research field of trying to understand how exercise might improve tolerance and efficacy. And again, these trials are early stage, but they're pointing some interesting data in terms of improving tolerance and efficacy from treatment. More work is required. So a take-home message, if you have prostate cancer, absolutely exercise is so important to improve function, preserve body composition during ADT, reduce fatigue during radiation therapy. For patients with advanced disease, exercise might preserve function as well, and it can be done using a modular components. The combination of resistance training and aerobic training, I believe Professor Newt spoke about some guidelines and recommendations, and I won't be touching again on this. It's likely, it's what has been endorsed by Exercise and Sports Science in Australia, and also the American College of Sports Medicine, so prescribing and individualizing exercise to these patients. And ideal and exercise physiology with expertise in training in this area can help patients with an exercise program. I just want to thank the Prostate Cancer Foundation of Australia for their incredible work nationally, and also for funding some important work, research work, and also services to the community in many states here in Australia. They, in particular for our group, they have been absolutely essential funding this early work. Other funding bodies as well, our staff here at the Exercise Medicine Research Institute, students, and also men with prostate cancer has been helping us extensively, giving their time for a lot of the studies that we do. And also acknowledge our research team. We cross our area within exercise oncology, crosses medical oncology, radiation oncology, psycho-oncology, urologists, cell biology, physiotherapy. So I want to thank the whole team for contributing to this work. Thank you very much, and I'm more than happy to answer questions. And I'm within the Exercise Medicine Research Institute at University. Thank you for your time.